Dr. Leah Houston, welcome to the show.
Thank you for having me.
So, I have had personal experience with identity theft about 2 years ago. Very stressful time, but my situation was a little bit boring in the sense that, somebody just tried to apply for a credit card, Wells Fargo, and it got flagged appropriately to the channels. And then I had to take all the appropriate measures, security monitoring, all that good stuff. Even though I'm very vigilant in terms of putting all the appropriate protections, but I was a victim of that. And the time around that was highly, highly stressful. And subsequent to that, just like constantly being hyper vigilant. You, my friend, you've had a slightly different experience. So why don't you tell the listeners with respect to, that type of story that you had, and then we can kind of get into how that led to where you are today.
So as an emergency doctor, I chose to do locums to have more control over my career. And so I worked at 10 or 12 different hospital systems and different places at different times, different states. I'm licensed in 3 different states. And one of the systems, when I stopped working there, they continued to bill under my name. And I had also decided I wasn't going to be working in that state anymore. So I let my license lapse. And because my license had lapsed, that's the only way I actually found out, because it alerted the Center for Medicare and Medicaid, hey, this doctor's practicing medicine without a license. But I wasn't. They were just using my Medicare, Medicaid, PCOS, PTAN numbers to bill. And yeah, it led me to be unable to work for 5 months. It was a long legal battle. I had to basically, you know, confront the hospital and prove that I was physically working in another place on the same days they claimed I was working there, which would have been physically impossible. So yeah, it kind of alerted me to this issue of, credential fraud and Medicare, Medicaid fraud in general.
Wow. My gut is, and kind of like the theme of the show is that we always want to point out the inefficiencies in the system. But there's this concept of most generous interpretation. So I'm going to apply it here. And I'm going to ask, do you think that this was maybe billers and coders in the back end? They just weren't aware that you're no longer there. As you investigated a little bit further, was it truly a nefarious thing that people were aware that you're no longer there? And for whatever reason they were doing that? What was that about?
Well, I've used the term RVU factory before, and that we as doctors are RVU factory workers turning out RVUs. And so the way things are built, if we as the doctors do it, they make more money. So if we physically do the chest compressions, or if we are the ones that actually place the Foley, they make more money. So in the emergency department, we could be supervising non-physician practitioners who are working in fast track. And I believe that the billers and coders in this situation were instructed to say that I was doing it so that the hospital could make more money. Now, we were considering approaching that during this experience, but we would have had to prove that they were purposefully doing it. And so that was
Sure.
difficult. But, why
Yeah.
else would they? It's kind of like the patients who, I lost my medications. All my pills fell down the sink. And it's always the Adderall
Right.
that falls down the sink. It's never
Or
their
the
atenolol,
narcotics.
which,
Yeah.
so, yeah.
That's really interesting. All right. So APNs, advanced practitioners, they don't generate as much in terms of as many RVUs. That certainly applies. So you're telling me, like, in a code situation, if medical students are doing chest compressions, like, first of all, people billing for codes?
Yeah, you get a lot of money for codes. You're sort of resuscitating somebody from the dead, So that's something
Huh.
that we're providing value there.
It
Resuscitation.
makes sense. Yeah, it's technically a procedure, but that
Yeah.
didn't even think of that. Wow. Okay. So that led you down to this new world that you're in right now. So tell us a little bit about this process. You brought up RVU and how important that is. We'll get, because I think that's maybe a little bit more in the billing thing, unless you think that it applies. I think listeners of the show are somewhat familiar with that. We brought up the relative value unit a couple of times and tried to explain it. If you think it's worth it, we can get into that. But talk a little bit about the whole physician credentialing process and what that entails. You've had to do it multiple times. And being a locum doc, I'm particularly curious how that works, because I think as a locum doc, you could be in one state 1 week, next month you could be a different state completely. What's that process like?
So credentialing, under the umbrella of credentialing, is 3 buckets. There's licensing, there's privileging of health systems, or telemedicine companies or any employer that you might work for as a doctor. You get privileged with that employer. And then there's the enrollment with payers, Medicare, Medicaid, insurance companies. So that under all those three of those things are credentialing. And in order to get paid, you have to be credentialed. In order for those RVUs to actually be paid out based on the ICD-10 coding handbook that's published by the AMA exclusively, you know, so it's all cobjob together and it's all interrelated. So our identity as doctors, our professional brand is essentially our credentials. Without having them, without having received them, without having being able to prove that they're real, primary source verification is the terminology that's used in the credentialing industry, then you can't get paid, you can't work, you can't move. So yeah, it's tightly tethered to payments and reimbursements and revenue cycle management and all those things too.
What do you mean you can't move?
Well, if you don't have a license, you can't
Right.
move to a different state. And if you don't get credentialed for privileging in a different hospital system, you can't move into a different system. And so, as a locums physician, if I wanted to take on a new opportunity, they could say you're hired today, but it would take 4 to 6 months for me to actually be able to start working. And that's the same, I think, in most other specialties as well. Sometimes longer. I mean, I've heard 11 months. I've had so many people say, oh my God, they promised the credentialing would take 4 months, but it took 7 months. I decided to just
Mhm.
take another job. But this is a significant barrier for us to be able to work, to move freely, to have an income, to have a say in how we work. And, I believe it's a significant indirect, influence on our autonomy because when you're credentialed at a hospital and you signed a contract and then they're not fulfilling their obligations of the contract, you now are kind of forced with just staying there and dealing with it for at least 4 to 6+ months while you look for another opportunity. Or just sometimes the administrative burden of having to credential somewhere else is just so much. You're like, oh, I'll just stay here. And so, in my opinion, credentials are being used as leverage for health systems to kind of gatekeep the talent pool. And so I believe solving it could create workforce mobility for us.
That's a really interesting point. I remember my brother, he's in this IT HR world, and him saying this, and I think I heard maybe on Diary of a CEO podcast, I think that person, Daniel Presley, is it? He's a big business builder type, getting startups and that kind of stuff. I remember him talking about the fastest way to increase your salary over time is to switch jobs. You could have, your annual 3%, 5%, but it's never going to compete with the person who switches every 2 years, every 3 years and stuff like that. And you're pointing out a big barrier to that. I think
Right.
that if you're going to get a 6 month break or a 4 month break, to be honest with you, maybe this is a little naive on my part. I thought that was a very location specific thing, in terms of administration, the environment that you're working on, but you're highlighting that this is kind of universal in the States at least. So that's disconcerting. What has it always been that way? Was it better in the golden age of medicine? Do we know?
Well, I can talk to you a little bit about the history of how this came about.
Okay.
So, physicians used to own their own private practices and then they used to get privileged at their local hospitals. And oftentimes they stayed in one community for their entire career. But we're in this new era where people want to not be employed. They want to be able to work part time. They want to be able to move around. So, over the last 30 years or so, this has really evolved. But back in 1996, the Center for Medicare and Medicaid put out a letter. It was a 1-page letter. And it said, hey, wait a second, we're not going to be paying hospitals anymore unless you verify that these doctors are safe to practice. And it was a very vague letter, but it was around the same time that HIPAA was created, 1996, same year. And hospitals were like, whoa, 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 what do you mean by that? We're already checking their licenses. What else do you want us to do? And so they basically developed a joint commission. And they said, okay, we have a sanctioning regulatory body that's going to make sure that you're doing the right thing. We're not going to tell you what to do. We're not going to create very clear standards, but we're going to say that you need to do the best that you can do. And this regulatory body is going to check up on you once in a while. And so because hospitals are so terrified of losing their accreditation, they kind of overcompensated and started checking everything. Your hospital affiliations, your procedure logs, your background checks, your, malpractice insurance, made sure that it was covering you in the right way. And so every hospital kind of has its own rules. And the Joint Commission comes in, as we all know, we've heard them, well, Joint Commission's in the hospital, put away your sodas and don't drink near the patient's bedside, blah, blah, blah. So, they come in and they just randomly pull files and they make sure that the doctors are credentials. That's one of the things that they do. And so, but this was before the digital era, before the internet, before, the cloud, before an ability to like rapidly digitally transfer and authenticate data and information. But those vestigial credentialing guidelines are still embedded in hospital systems and in regulatory bodies like the Joint Commission and NCQA, which is the one that does it for payers and insurance companies.
Yeah. Thanks for that history. I had no idea about that. And Alpamacho and I always talk about how there's still this old school mentality when it comes to hospitals and the regulations, and it just takes forever for things to come through, as you said, in this digital era. I mean, we're finally seeing AI come into Epic with some of the bots that they're releasing, but for that to kind of take over and to really help physicians, I always talk about, I think it's still going to take some time. So I just wanted to get into, just for some clarification here. So, and for the audience so that they know. So I have my NPI, right? That's my national provider identification. That stays with me wherever I go. Then you have your state license, which will be different, obviously, state to state, that you have to renew every 2 years or whatever. And then you're also talking about, once you have those, when you get a job and you sign your contract with the hospital, they have their own credentialing process that can take whatever, 2, 3, 4, 5 months, up to a year, some, as you said. So as we talk about how there's no real forward thinking in a way, I guess, I mean, this is where you come into play. Where's the root cause in all this? Is it really that we just haven't come up with a solution? Or is there a stopgap somewhere that if we just pull, hey, a lot of this can start to flow?
Well, the thing is we as physicians have been super disempowered. And even though we sit on leadership positions at hospitals, we kind of are like doing as we're told out of fear of retaliation, out of fear, we don't want to rock the boat. We don't want to be labeled disruptive. And so, these standards can be changed. So in every hospital system, there's bylaws that say, hey, these are the things that you need to check. These are the things that we accept. These are the things that are okay. And it just takes a vote with the hospital systems to change the bylaws. I don't necessarily think that a lot needs to be changed, but I do think that we need to start adopting digital tools. So you mentioned Epic and how they're basically building out some AI scribe technology. Is that right? I think I read about that.
Mm-hmm.
What we're doing at the companies, we're building out agents that actually do the entire credentialing process for you. So we're eliminating all of the redundant manual entry, all of the redundant authentication, and we're giving you your data that's already pre-verified. So when it's shared, that, credentialing process can be shortened, hopefully to moments. That's the goal.
So I'm going to assume that this has tried to be done before, at least like a single system where you put in all your information, does the checks for you, and then it sends it out to different states and different hospitals. Were there any shortcomings from anything from previous attempts at trying to do this?
It's never been tried before because LLMs weren't available until now.
Gotcha. So really AI and using that, but not even like, I don't know, just trying to think of a system where I can pay a little bit extra. They will do the background check and everything for me, have a more centralized system, and then just, do everything.
Right. I mean, there's huge farms of hundreds of people overseas in the Philippines and Pakistan, where they basically work for these credentialing companies and they have humans that are actually actively doing these things and actually going to these websites and testing things. However,
Gotcha.
That's the old way of doing things, right? So
Yep.
There's two opportunities now that can be leveraged. Not only can we leverage LLMs to allow agents to essentially do the busy work for you and work just as they are these individual credentialing specialists overseas, but we also have APIs, which are essentially access portals to external data sources so that we can retrieve this information instantaneously. So for example, the state of California has an API to their medical licensing database. So we can connect to that database, authenticate your license permanently, perpetually in real time. Other states that don't have an API, we can let the agents do that work for you.
Sorry, Leah, can you explain API one more time for the person who isn't deep into this world?
API, I think it stands for Application Programming Interface. And it basically is, if you have a software system and it's connected to the internet, you can build an API to an external system like the state of California Medical License Database. The American Board of Medical Specialties has an API. The AMA has an API to the practitioner profile. CAQH has an API. So, that's been developed probably over the last 10 years or so. Not everywhere, but the ecosystem is slowly evolving. And the guidelines regarding credentialing, the deadlines are tightening. So it used to be that you have to check every 90 days or every 120 days to make sure that the license is active. They're tightening that window to every 30 days because of the risk that, you book a surgery for 2 months from now, and today the surgeon's licensed, but 2 months from now, are they? And are they walking to the OR unlicensed because they forgot to renew their license? I mean, since I've started this, I've gotten so many phone calls. Oh my God, I found out my license was expired. I found out my DA was expired. And they're only finding out because they tried to write a prescription or something like that.
Right. So it's a much more proactive thing. I come back to the credentialing process. I think, so every state has their own, with each individual payers, whether it's the commercial payers, even with the state Medicaid system. I can understand how if you go from, let's just say, if I go from New Jersey to California, I would have to get recredentialed. But Medicare is at the federal level, right? So maybe I should ask this is, if I go, is that, at least with Medicare, is that process a little bit faster to get recredentialed there, or?
Medicare and Medicaid take the longest.
Oh, great.
And they're state-specific sponsors, right? So even though there's a federal, umbrella, each state has its own agency that actually, fulfills that.
Interesting.
Yeah.
So the other question is, my understanding is with the licensing, because I am licensed in multiple states, and I know that there are some states, I think it's called the IMLC, right? The Interstate Medical Licensure Compact, where basically there's another one too that's not coming to mind right now. Certain states have that. There's like, I don't know, at least it's not all 50 of them, but the idea is that it's supposed to make the process more efficient. If you get verified with these people, you have to pay a ton of fees to get this IMLC. Then if you move to a different state, if I want to get licensed in Florida, that process will be a lot faster. Did we ever have anything of the sort for credentialing?
So, I mean, licensing is under the umbrella of credentialing.
Sure.
So that is one piece.
But with payers, I mean, with payers or like that type of credentialing, that bucket of credentialing rather.
Well, so here's the thing. On one hand, the payers and the hospital systems find this to be a huge pain point, and they find it to be very inefficient. And they themselves have kind of scattered standards that are based on this letter from 1996 that I mentioned. But on the other hand, it is a tool for gatekeeping physician talent and keeping doctors in their own system. So they can have you sign a non-compete, saying that you won't work somewhere else. They can have you language in the contract saying that you won't refer patients outside of the hospital. And they also have this credentialing tool to say, hey, we know it's going to be hard for them to leave. So, but I do want to talk to you about interstate medical licensing reciprocity. So I'm sure all of us have a driver's license. If I drive over the border into another state, am I doing something illegal? No, because driving is the same in one state versus another, but it's the same for medicine too. Medicine's the same in one state or another. So why have we not created interstate medical licensing reciprocity? Why have we not, as a physician community, pushed for this? Why hasn't the AMA advocated for this? It's because of money. It's because of money and control. Like you said, even with the IMLC, the Interstate Medical Licensing Compact, you still have to pay every single licensing fee. You still have to do different CME requirements. Some of them overlap, some of them don't, in order to maintain these licenses. It's all, in my opinion, it's a racket, and it's part of what we as a company would like to start advocating around. But in order to do that, we need to kind of collectively organize. And that's definitely something we care about.
I just want to take the opposing viewpoint for a second. Could it be that I'm trying to think of circumstances where certain state rules require you to practice medicine a little different way? Nothing comes to mind. Again, I haven't practiced in multiple states, so I can't. But like we do know that the laws, at least ours practice in Florida, I'm in New Jersey, with respect to inpatient patient care. Also, when you're prescribing opioid medications, I think in Florida, Darcy, you told me you can only do a 3-day or some version of that, right? In New Jersey, it's 3 days, right? In New Jersey, it's 5 days. So there are this little minutia. Again, I agree with you. Largely, I would say 95% of medicine. But could they make the argument that this is for patient safety provider safety, that you have to be compliant with their laws, licensed with their laws. So we understand that you understand specifically what the requirements of this state are.
I mean, I have nothing against medical licensing. I think we should be licensed to practice because I think that there are safety issues around it. I think what I'm trying to say is the current system is extremely cumbersome, unnecessarily administratively burdensome, where, if, for example, the state of Florida wanted to collaborate with other states in the Southeast or other states that had the same ethos around the practice of medicine and say, hey, if you have a Georgia medical license, you can also practice in Florida, but you have to take this one other controlled substance database, CME, and pay this additional fee to add on the Florida license, rather than having completely separate, very, duplicative efforts is what I'm feeling. And I only have 3 licenses. I don't know how many you have, but some people that have used our wallet have 50 licenses. And I'm just like, wow, like maintenance of that is just nuts. So yeah.
Okay, cool. So what's the fix? What do we do?
Well, so I believe the fix is for us to own our data and to have this pre-verified data in our wallet and allow agents to do the heavy lifting for us. So, whenever I have to renew my licenses, I'm always like looking at all the CMEs that I need to do for each license. And I'm like, oh, okay, I need to do at least, 3 hours or 4 hours of, opiate prescribing CME. And I need to do that also in Florida, and I need to do that in California. So let me see which one works for both so I don't have to take it twice. So, but that's like my own cognitive energy that I have to do. And it's really annoying. And I'm looking for the cheapest CME and the one that's easiest to do and the one that. So if we have agents that are working on our behalf, that are doing that work for us and just funneling in, hey, do these 3 CMEs. It'll be good for your Florida and your Nebraska license. And then all we have to do is actually just do the CME, actually fill out the form, actually pay the fee, and not do all this extra duplicative effort stuff. Just reducing administrative burden. That's it.
And just to clarify for those who are not potentially following on, we're talking about AI agents, correct?
Yes.
Can you explain to those people who are maybe not as savvy with all the LLMs that are out there is what the heck are agents and how do they specifically even work?
Yeah. I mean, so we've heard of LLMs, large language models. That's basically like the way I look at it, it's like the collective consciousness of the internet or whatever data infrastructure that you put into these LLMs. And it's able to learn and behave and act as a human. It's able to think because it takes all of this information and is able to process it and essentially make decisions for you on your behalf. So, for example, with our product, you can upload your credentialing documents and we read the document. We just determine what kind of document it is. We fill out all the information. But then, of course, you as a human can say, yes, I agree. And so that way you're not manually putting it in, but you're just like having the busy work done for you. Now, when it comes to renewing your license, applying for your license, sharing your credentials, responding to credential verification requests, the agents can also make recommendations. Hey, your license is going to renew in 3 months. You have to do these 4 CMEs. Would you like me to make some recommendations on what CMEs to do? And we can send you to the ones that are going to be the least amount of time, the least amount of money. We can collaborate with CME companies to do that. And, we can also build community around this too, which I think would be good for us as practicing doctors who want to have independence, who want to build our own referral networks, who want to have some kind of professional brand that's ours, that's owned by us and not tethered to systems. And so I think that this is a very exciting future. And yeah, I don't know if I explained agents well enough though. Yeah.
Yeah, I think so. Yeah, I'm like you said, I think it's gonna be an awesome feature where we have agents really just doing some of that work for us. I mean, I think ChatGPT 5 now has something similar. I mean, it's not quite to maybe what Elon's trying to build at X, but you can just say the flights that you want to go to. So I have a wedding to go to end of September, and it mapped out everything. Here are the best flights. Here are the best rental cars. You kind of choose what you want to do. But at least, like you said, I don't have to have that cognitive load now to put in those extra efforts and waste my time when I can be doing something else. So Yeah, definitely
Right.
exciting.
And our time is money, So,
Yeah, 100%. You also mentioned wallet. And, when people think wallet in the digital sense, they might be thinking crypto, right? But with that comes the blockchain and all these other different things. Do you mind digging a little bit deeper in terms of all the other things that are part of the solution that you're creating?
100%. So the company is called HPAC, stands for Humanitarian Physicians Empowerment Community. And our original application was a decentralized identity application. Now, decentralized identity is a protocol that's similar to crypto protocols, but it's for data. So there's public private key pairs. And just like you have your private key, and that's your crypto wallet, you can have your private key to your decentralized identity, and that's your credential data wallet. And
Mhm.
so we built out an initial version of that, and it didn't fully come to fruition, but we still do have the vision of having complete and true ownership over your data. And we are currently collaborating with a couple of other healthcare companies in the decentralization space to essentially build a Bitcoin-backed payment engine where physicians can be paid directly for their services at the time of service. We can build payment engines where you basically name your price, opt into being in a network of practitioners or physicians who offer these services, and patients can easily find you, easily pay you directly for services. We can layer in HSAs so that you can have, pre-tax dollars to use for this. And we can also collaborate with large employers who want to offer this as either complete alternative to health insurance or as a supplement to health insurance, reducing the actual cost of medical care by 30 to 60%, depending on what exactly is going on. Because we know that physicians make about 7% of every healthcare dollar, and about 30% is wasted on administrative stuff. So if the agents are doing the admin, if the payment engines are essentially self-healing and auto-updating based on feedback, then we can reduce a lot of waste.
Got it.
Lee, I'm confused. How would it supplement or replace the need for health insurance?
Well, health insurance is kind of a relatively new concept, Historically, it was kind of created in the 50s in order to entice people to get back to work. And it was, created as like this additional perk that you get if you come back to work. And then in the 90s, they started, essentially incentivizing employers through government programs to offer this benefit. And then with the ACA, it got even more crazy with the incentivization structure where they're now penalizing people that don't purchase this product.
Mhm.
And so people used to pay directly for their healthcare. We know that if you're paying for healthcare, it's actually not that expensive if you're paying directly. The direct primary care community has created a system where patients have immediate access to their doctor. They can text with them. They can see them the next day for urgent appointments. And they're paying somewhere between 100 and 150 bucks a month, which is nothing. And so, if we are able to create direct payment models and physicians are able to name their price for the procedures that they charge, and they know that they're actually going to get paid and they're not going to have to hire 5 staff members to do the revenue cycle management for them, and they're not going to wonder if there's going to be a clawback because they're paid immediately directly at the time of service based on the infrastructure that we build, then the administrative cost goes down. So am I saying that? I mean, I don't have health insurance. I have a health sharing plan. So I decided a long time ago that health insurance was a scam. I'd been paying for it for 6 or 7 years. I'd never used it. I used it once and I still got a $4,800 bill because I hadn't hit my deductible that year. And I was like, this is a scam. So health sharing covers catastrophic costs, and then you pay out of pocket for every non-emergency issue. And then I also have an HSA. So that's a choice I'm making. It's a risk I'm taking. I'm a single woman, no kids, not married. So it's different for some people. But when people look at the cost of health insurance and the value that they're getting it, I mean, like large employers are paying $14,000, $15,000 per covered employee. That with the deductibles is making it unaffordable. And especially when you notice that doctors aren't actually getting paid for the services that are rendered because insurance companies are putting up these prior authorization, bottlenecks that make it impossible to actually get paid for services that are already rendered. It's very clear that it's just broken and not working.
Does a health sharing plan satisfy the ACA requirements, or do you still get penalized?
It does not, but this administration might be changing that.
how does someone go about if they're interested? Is that something that you can go on to healthcare.gov, or how does somebody?
Well, so health sharing is not insurance. Health sharing, a significant number of people put their money into a pool of funds.
Okay.
And then when something happens, you basically say, hey, I'm a self-pay. And then your health sharing plan does the cash negotiation with the health systems. And so because the facilities fees and all these things are tagged on, basically because insurance has overinflated the price of healthcare or the cost of healthcare, health sharing plans are often able to negotiate that cash price down, and then they pay the hospital directly. And because they'll be like, oh, we'll pay you tomorrow, but we'd like you to give us a discount. Hospitals are like, oh my God, you're going to pay us tomorrow. We don't have to go through a 6-month, RCM, back and forth with the prior authorization process. Sure, we'll take it, So,
But
um,
yeah, I apologize. Who's managing it though? Like you said, significant number of people. We're probably talking in the thousands, right? Like a very large number of people to
yeah,
come
yeah, yeah.
together. Who's
Mhm.
managing it though? Are they still the companies that people would have heard of in terms of a branch of
I can
United is
name
doing
some
that, or?
companies. So, like Liberty Health Share is one of the oldest
Okay.
ones. A lot of them were called Christian health sharing ministries because, like, people wanted faith based organizations to
Yeah.
kind of be able to provide health, and not insurance, but health care access for their members. There's Sedera is another one, and MBVIP is another one. Zion Health is another one. Um,
So this is not something somebody would just trip over. You have to actively be looking for this.
You have to actively look for it. I mean, I have some friends who are in the financial services industry, and they often recommend this to their high net worth clients because it's overall smarter and better to not waste money on health insurance, and you can have more choice.
Right.
And, you don't have to be only going to this facility or that facility and, only doing network. You go wherever you want.
Sweet. I want to come back to employing agents to do some of the scut work, if you will,
Yeah.
right? Today, I was reading a newsletter where OpenAI can flag any parts of your conversation that they determine might be harmful either to yourself or to somebody else and give it to the police. It can end up in a police report. Sam Altman's talked about this for the last couple of weeks. I've heard him on different podcasts. I've heard him in the news talk about, hey, people are sharing their deepest, darkest secrets with these large, these LLMs with Claude, and they're so good. People are oftentimes outsourcing the need for a therapist. And all this stuff can be subpoenaed. All this stuff can be used against you. We're even finding out instances where this stuff is actually getting leaked. And I think not a lot of people are bullish on AI, right? I hear a lot of really smart people who've left the industry and are now talking about some of the concerns that they have. And I actually share some of those concerns. It hasn't stopped me. I use it like 24/7. But, it begs the question is like, what are some of the security concerns with those agents? Because you started with that you get to own your own data. But one, I would think that, these agents, ChatGPT or Claude or Gemini, they still, I wouldn't even necessarily say hallucinate, but they're still largely inaccurate on a lot of really important things. And I use it as a thought partner for a lot of healthcare related decision making. And I find that, in the
It's
domains
wrong
where I am an
sometimes.
expert, it's not very good.
Mhm.
And so, if you kind of just outsource this, and we all know that like when you have a document that has 200 questions and you're like, does this look good to you? Technically, people just sign off, right? Those terms and conditions, you just, yeah, 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 I agree. Does that give you some concern? And if not, are there any concerns that you have with this type of model employing it for security reasons?
So OpenAI and Claude and Grok, they're all private companies that have these models that are taking our information and learning on it, training it and all that kind of stuff. And I don't know the specifics. So, I'm not an expert in these different companies. What we're doing differently is we're creating domain specific large language models that are owned by the company. So as long as you trust Evercred as a company, then you don't have to worry about that. And I also want to point out that, like, right now, our data is being sold. It's being sold all over the place. When we get a job, we sign an agreement saying, oh, here's my passwords to my CAQH, here's my passwords to my FSMB, or we just give these people who are then handing them to some $4 an hour VA in, Pakistan who does God knows what with our data. On top of that insecurity, they also now have all of our credentialing data and they're selling it and they're sharing it. So we have zero protection right now. And so if we have a domain specific LLM that's owned and controlled by the company that isn't using any external large language models, then that risk is reduced. And we have people on our technical team who have a lot of experience with SOC 2 compliance and HIPAA and privacy, people who were at the head of privacy at AI, which was one of the first AI healthcare companies. So I really feel strongly that we will not have a problem with that. But you just have to trust us as a company. But, we're building this. We are a physician-owned company. We are physician, developed with doctors in mind to specifically solve this problem. So it is a concern, though, something to think about.
I'm assuming blockchain adds another layer of security, though, right? I mean, that's one of the things that it touts on. And if you don't mind, can you explain blockchain? I did take a masterclass on it, but I probably forgot about 80% of everything I learned. But, just in general terms, what blockchain actually means and why it's used.
So I'll do a little history lesson again. So like back in the day, back in feudal Europe, we had the merchants bringing their goods across the different countries and selling their merchandise. And when there were people buying and selling goods, they kept a ledger. And they said, okay, how many barrels of grain did you have? How many, rolls of silk did you have? And they realized that it was hard to discern who was actually buying and selling unless they had a duplicate ledger that they could look at it and say, hey, this person sold this and it matches this other ledger. And so duplicative ledgers have been used throughout history for commerce. And so what blockchain is it's a digital duplicative ledger. So when something happens on a blockchain, it is instantaneously copied on thousands of different ledgers. And so essentially, those ledgers are also constantly checked and updated. So we hear, so basically, if I make a transaction with you, we put the block on the blockchain, it's instantaneously duplicated. And then across the world, we have these miners, at least this is for the Bitcoin blockchain, who are checking these ledgers and making sure they're all the same. So they basically only accept additions to this duplicative ledger when more than 50% of people have agreed that it's a transaction that actually happened. And so the other important piece is that this is immutable. So once a block is placed in the blockchain and once it's duplicated, you can't erase or go back. And so it basically creates a permanent, perpetual business log, business record of the transactions that actually happened. And so it creates a system of trust that's developed in code that doesn't require humans to decide. You go to Chase Bank, you go to any bank, and essentially they have their centralized database, their centralized servers. And, a friend of mine, her brother was involved in a business transaction, and it was with somebody who then was later investigated by the feds. And they had a family bank account from since childhood. And so her assets were all frozen because she had an kill with her brother, who then had this business thing happen with this guy. And she was in this, they froze her assets. So there's still centralization and control when there's one point of failure. With, Bitcoin, with blockchain, with cryptocurrency that is actually fully distributed and fully decentralized, that risk approaches zero, unless there's a 51% attack. Now, the risk that comes along with that is then you are fully in control of your private keys and you are fully at risk if you lose those keys, which a lot of people have lost their Bitcoin way. Does that make sense?
Yeah, no, absolutely. I love that. That's perfect. I love the history lessons as well. I think it makes it very relatable, easy to understand. So thank you for that. So you talked about how these solutions definitely work on an individual level, right? As a physician, myself, Ultimash, we can buy into this. It makes it easier for us to get our CMEs, have everything in one place, the payments, all of it. What is the broader impact of what you're thinking about? How does it now affect hospital systems, cross state? Where do we take it from here?
I mean, I feel like patients are frustrated. They are diagnosed with colon cancer And all of a sudden they need to find a colorectal surgeon and an oncologist. And they're, okay, I can look at this roster on my, insurance list of in-network providers. I can look at Google reviews, but are they really the right person for me? Especially now with advancements in genetics, proteomics, genomics, where you're getting more granular understanding of, the actual, genomics of your tumors and things like that. And, wanting to really go to the right person for you, wanting to have that precision level care, and that's on the medical and the scientific side. There's also the social component of it. People want doctors that they can relate to, that share their value systems, especially in, the functional medicine space, the longevity space. People kind of want to do things a little bit outside the box, and they want to find, physicians who are in alignment with their value systems, who are willing to supplement their T if their T is low normal, but they're having symptoms of hypothyroidism, for example. And, we as physicians have always historically been able to make these calls, but under the insurance model, under the employment model, we've been kind of prevented from having that kind of autonomy. So if we can create an interphysician referral network of doctors who are able to practice on their terms, who are able to serve patients, where patients are able to find the right doctor for them easily and quickly because their credentials are easily accessible and physicians are able to advertise and work in collaboration with other practitioners who are in alignment with their value systems and with their, their competency and their skill sets, then we can kind of usurp the whole healthcare system. And I know that sounds kind of grandiose, but I think that both patients and physicians are frustrated to the point that we're ready for something like this. So it's really exciting.
I can see the excitement in your face with every answer that you give us. And I'm wondering, Leah, why is this so important to you? Is it all because of that one incident? Or is this something that's been brewing in the back of your mind for a long time?
So a couple of things, I, like every physician out there, spent my entire youth with my nose in a book, learning how to prevent death and permanent disability, understanding on a molecular level, the organic, chemistry interactions that, lead to the Krebs cycle and all this stuff. And I did all of this work. I worked these 15-hour days throughout my entire 20s and 30s with the expectation that when I exited, I would actually be able to serve people and do the right thing for them. But I was basically thrust into a system where I was forced to practice unethical medicine or not have a job. And I think a lot of physicians are feeling this way. And that's why there's a mass exodus. That's why there's a high suicide rate. And so it's really about knowing what we deserve as physicians and what our patients deserve. Our patients deserve to have people that are advocating for them. We are to be of service for them, not this system. And, I've had my own experiences. Like, my mother suffered from leukemia. And I was very lucky because not only am I a physician, but I also know so many people that I was able to find the right person for her. And then I also was able to kind of make some recommendations and influence her care. So, my mom's a tiny woman. She's 4'8". She was 100 pounds. And she had gone through a couple of the different regimens for chemotherapy, and she was having severe reactions to all of them. And I said, wait a second, what if we lower the dose? They lower the dose, she was fine. So that recommendation was only made because I was a doctor and because, the physician that was working with us felt, okay, well, I'm able to do this because the patient asked for it. It's not part of the protocol, but I can document that we had a discussion about the risks and the benefits, and I can give this a try because they're requesting it. So I want that for everybody. I want to have that when I'm 80 years old. I want to know that if I get rolled into an emergency department with a stroke, that somebody that is as, that cares as much about as I cared about my patients is going to be available to take care of me. And right now with this assembly line medicine problem, it's not going to be that case. So we have to fix it.
Yeah. And I think you kind of highlighted this. I'd even go as far as to say that that doctor probably, gave you that respect, that professional courtesy. Oh, look, she's also a physician, so I'm more likely to listen to her. Right. Whereas if it was another patient who had looked that up on ChatGPT or Googled it, even if it had the same amount of accuracy behind that, or, as reasonable of a suggestion, they might dismiss that person because they don't have that background training and stuff. And I often talk about this. I think Darsh and I have talked about this offline, how much of a privilege it is to be in healthcare and then to be that resource for those that you love, with aging parents. And you talked about, right, being able to advocate for them, being able to connect the dots, being able to interpret why certain things are the way they are, and always keeping that forefront when you are serving patients and when you're sitting in this role. And you're taking care of a 75-year-old who's 3 months out of a stroke, maybe a little less, maybe a month out of stroke, and the inpatient rehab unit, and you're like, man, that could be my mom, that could be my dad. So I should potentially give them this same type of energy that I would ask for if I was sitting at bedside with them and advocating for them. So I love that. I love your mission. I do have an important question for you. You mentioned earlier, when you're contrasting Evercred or excuse me, HPAC and, some of the other big companies, private organizations out there who are employing LLMs and really trying to maximize their utility. You used an important word. You said trust. We have to trust you. And I'm sure somebody out there who's listening and said, well, why should we trust you? And why is this something that's worth investing in?
Well, I'm a physician. I took the Hippocratic Oath. I could be making 400K a year as an emergency doctor, just stacking cash and retiring as early as possible to get out of this system and, wish the rest of the world luck. But I've chosen to essentially dedicate more time than I've dedicated during medical school and residency to build a solution for us and to solve this problem for us. And, you know, it's important for me because I think that we need this. And, you mentioned that if a patient comes in with, oh, ChatGPT said this or that, there's this lie that's being told that doctors don't care. I think it's more that we don't have time, where we have this cognitive overload where it's, yeah, if I had an extra 30 minutes to review what you found and read about it, and if I was going to be paid for that time, then yes, I could have this conversation with you and understand the risks and the benefits and have that, consent conversation and make a decision with you, which is what doctors used to do in the 50s. But patients have this perception that we're stupid, that we don't care, that we don't know anything. But it's really that we are being controlled by the employment and insurance model. And even if we do want to give that extra time and we want to give that extra attention, we often have no say. And we're also practicing defensive medicine under that model. So, I want to untether the physician community from the medical industrial complex. I want us to have autonomy and agency to practice and to serve our patients directly without influence, without inappropriate influence from all of these external sources.
Yeah. How, if somebody wants to help you get there faster, how do we do that? How do we make it successful?
Well, so join the app. It's free to use. You can go to our website, evercred.com, click join us. You can download the application. If you have a small practice and you need a credentialing solution, we are rolling out sharing and we're basically building out a full credentialing system where we're building out the agents. October should be the deadline for the first sharing version. And then we're going to be continuing to iterate on that. We've already signed a large practice group, and we have a couple of others in the pipeline. And, we are going to be opening up an investment round. So if you are interested in investing, reach out to us. There's a contact us button on the website as well. Follow us over social media. We're on all platforms, Evercred, Leah Houston, MD. You can follow me as well. And we want to hear your feedback. This is a new idea. This is a new solution. We believe it is the key to essentially fixing this, healthcare system mess that we're in. But I'm also not closed to other ideas.
It's awesome. I'm on it. On the mobile app right now on the website. So yeah, this looks great. Leah, I'm very curious. How did you get into this tech world? Obviously you have your story, but how did you learn all of it? Because one of the things as a mentor, I mentee a lot of pre-med students, I talk about building range and being diverse and having different skill sets. And oftentimes, in our fields, everyone is so siloed, right? Our sports medicine, PM&R, like even though Altmarsh and I are PM&R, we'll still do completely different things in our respective settings. So how did you get into tech?
So I entered as an attending and I was immediately disillusioned. I was like, this is crazy. I'm being forced to see more patients that are safe. I don't have the resources I need. It's an understaffed emergency department. I need to figure out how to stack cash and retire early. And so I started learning about stocks. And in 2012, I was investing in Tesla and Facebook, in Bitcoin, and I just was learning about this stuff. And then I moved to Silicon Valley in 2014, where I got to meet a lot of these tech entrepreneurs and like really dig into it. And they started asking me advice and feedback on their health tech platform. So, for example, this Theranos deck came across my desk in 2014. And they're like, what do you think about this? And I'm like, it looks like a scam to me. And so I kind of just
Wow.
from being in Silicon Valley was kind of exposed to the tech world. And then after the identity theft issue, I realized that this was a solution. So it was more like solving a problem that led me and just being curious and wanting to learn about it. Yeah.
Yeah. Awesome. Love that. Ultimate, any questions? Leah, is there anything that we haven't touched on that you think would be important to?
No, I mean, I think I just want to make it clear that yes, this is a credentialing solution. Yes, credentialing is a huge administrative burden. Yes, it's a $5 billion problem. Yes, we want to reduce all this nonsense that we have to do, but this is really a movement to save medicine. It's a movement to allow doctors to work and move freely, allow us to collaborate and to have autonomy again on top of it. So
I love it. Are you doing any more locums work? Are you still practicing medicine at all in
I
the traditional
am
sense?
practicing. I have a small panel of private patients that I see, but it's more like people that couldn't find care and they wanted my help. So it's
More
not,
for like from a primary, like a direct
it's
practitioner type
more
stuff?
direct primary care, but it's longevity and urgent care that I'm doing also. Knowing who I know, I mean, I have a network of over 60,000 physicians. I've learned a lot about the stem cell space. I have a background in molecular biology and biochemistry. I know a lot about the peptide space. It's just been something I've been following. I almost started my own private practice in 2017 to kind of get out of the rat race. And I started learning about it and following it then. So yeah,
I
staying in
love it.
touch with.
For we've talked about DPC and direct specialty care, which is
Mhm.
kind of where Darsh and I live, I suppose, or soon, hopefully. Those folks don't need to be credentialed with payers, right? But licensing, of course, can matter. I mean, how could they benefit aside from the resources and network? Could they utilize the resources with respect to the app and the services?
Yeah, so direct primary care docs can join. Joining the app is free. The basic version is free. And, they can get their one license tracked all for free. The benefit that they can have is the network. So, one thing that I keep seeing in every single private DPC group is where do I send my patient for this? Where do I send my patient for that?
Mhm.
How do I know that I'm sending my patient to somebody who isn't going to essentially you know, advise them to go to this hospital system and to do these wrong things. So it's really about the referral network piece that I think would be beneficial to DPC. I have a lot of respect for the DPC community. There's a couple of the original DPC docs who actually invested in this because they acknowledge that DPC is not scalable unless you have infrastructure for this referral network piece. And so it's really more the community piece that I think can help DPC docs. But yeah,
Can I ask, Leah, where do you realistically think with this new administration within the next 10 years, where's healthcare going to be? What's it going to look like in the next 5, 10 years?
well, I think that there's a lot of movement in the what people call functional medicine, but I really call the longevity space. People are going to have more of their own data. They're people are getting whoops and aura rings and they're having a better understanding of like their own, sleep cycles and things like that. The ability to sequence genomes has become more and more accessible. So having a better understanding of your genetic markers, your proteomics, your genomics. And I think that, I mean, people can buy peptides online without a doctor's prescription. So I think there's going to be more and more people that are like usurping the physician community to do stuff. I'll make ourselves available to help guide them. Now, I also see a lot of potential in the psychedelic space. There's a lot of research in psilocybin and ibogaine and how it can help improve symptoms of depression. And so I think that essentially people are going rogue and they're doing what they know is best for them. And that could, lead to some people going down a rabbit hole and harming themselves. But if we as physicians step up, acknowledge this, lean into it, learn as much as we can about this space and offer ourselves in whatever framework and capacity we feel comfortable to serve this patient population, then we can really, make a big difference in people's lives.
Well, with that, I mean, I can't think of a perfect guest to bring on to our show. Honestly, everything you've touched on, the solutions, this is really what Medicine Redefined about. It's about bringing these real-time solutions, talking about the problem, the root cause, and bringing everyone together, which is what you're doing. So with that, our last question that we ask everyone, and feel free to be as brief or as long as you want, is how do we put the health back in healthcare?
I think it's untethering the physician community from the medical industrial complex, which is why I'm doing this. I think, we are extremely knowledgeable. We understand the root cause of what's going on in healthcare, but we are, forced into these models where we're practicing assembly line medicine, where we're practicing defensive medicine, where our employers and the insurance companies are influencing how we practice. We need to untether ourselves from that. We need to stop being afraid. And as soon as we do that, then patients will better be served.
Love it.
I love it.
Leah, you've been
Till
great.
next time.
Thank you.
It's been such a pleasure. I'm really looking forward to seeing how this turns out.
Thanks, Lee. Thanks for listening to another episode of Medicine Redefined. If you enjoyed this episode, please be sure to check out some of the additional resources in the show notes. Please also check out our social media platforms where you can find more content like this. You can follow us on Instagram, Twitter, and TikTok at Med Redefined. We also want to thank our team for the production of this podcast, Arita Yepuri on social media, Zainab Lugmani on research, and Sarah Khan for newsletter. Oh, and if you want to get similar bite-sized information delivered to your inbox every Sunday, please be sure to sign up for our newsletter. Also, if you enjoyed the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this as well. Now, time for the ever so important disclaimers. This podcast is intended for general public use and is for educational purposes only. It does not constitute the practice of medicine, nor should be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues.